Good evening, everybody. My name is Gabe Lewis, and I am the marketing director for Lumibird Medical. And I want to welcome you to Advancements in Ophthalmology featuring PROcap, which is Premium Refractive Outcome Capsulotomies. The goal of the evening is to shed new light on a better way of doing capsulotomies, the final stage in the premium cataract patient experience. Dr. Paul Singh will be joining us in a couple minutes to lead the discussion. Dr. Singh, along with Carl Brasa, has been instrumental in the development of PROcap. And we believe with his expertise and the newest technology from Lumibird Medical, capsulotomies can not only be standardized, but you can achieve consistent, predictable results. Dr. Singh is a Wisconsin native and is the president of the Eye Centers of Racine and Kenosha. He was a chief resident and completed his residency at Cook County Hospital, Division of Ophthalmology, and his internship at Michael Reese Hospital, Department of Medicine, both in Chicago. He graduated from Finch University of Health Sciences, the Chicago Medical School, in 1999. His undergraduate education was completed at Washington University in St. Louis with a BA in biology and psychology. He completed his fellowship in glaucoma at Duke University in July 2004 before returning to his hometown, where he is currently in private practice. Throughout his ophthalmology career, Dr. Singh has been involved with extensive clinical research and has published many papers in ophthalmology journals. He has also presented his research at various national meetings and universities around the world. He maintains a full-time research facility and is currently involved in industry-sponsored and independent research in glaucoma, cataract, ocular surface disease, and retina. Newsweek named Dr. Singh America's best eye doctor in 2021 for quality of care, continuity of care, and the quality of the technology used in his practice. And without further ado, I want to turn it over to Paul Singh, but I do want to mention we do have a Q&A function. So if you do have any questions throughout the presentation, I will, if you want to put that in, we'll open it up at the end and Dr. Singh will answer those questions. So again, without further ado, Dr. Singh.
All right. Well, thank you, Gabe, and thank you everybody out there for joining us on this Tuesday evening. I know you guys have a lot of stuff going on an evening like this, so I appreciate that. We'll keep it hopefully efficient, but keep it interactive. If you have any comments, any questions, please feel free to share. By the way, I'm Gabe. You didn't have to go through all those dates with my training, because that means I'm old. When you said 1999, I was like, oh my God, that is so long ago. Oh my gosh. But yes, I'm in Wisconsin. I'm not in Wisconsin in this backdrop here. This is my Miami dream loft. But thank God for Zoom, right? But I grew up here in Wisconsin, so I'm back as a Cheesehead Packer fan, and my dad was an ophthalmologist, and I got really excited about the idea of new technology from my father. I mean, he was the first to do a lens implant in the state of Wisconsin back in the 70s, to do RK and LASIK and you name it. And I got the itch from him, and because I kind of keep moving forward. My dad taught me a lot of not being complacent, and it's not that we have to always keep doing new things just for the sake of it, but can we get better at what we do? I mean, we can take a cataract surgery from 25 years ago and we were pretty good, but look what's happened now, right? How far we've come. And I think that's the idea of something like PROcap. It's not revolutionary, going to change our whole practice forever, but can we do a better job with our YAG capsulotomies? And what does it mean, and what does it entail? And so that's what we'll talk about tonight when it comes to PROcap. I'm actually a glaucoma trained, as Gabe mentioned, from Duke, but I do a lot of anterior segment refractive cataract surgery, a lot of cataracts, a lot of MIGS, a lot of refractives, LASIK, SMILE, et cetera. And so we see the expectation of our patients is so much greater than ever before. And so when we talk about what does it mean to talk about PROcap, what does it really mean exactly? For me, I got to do my videos. But what does PROcap really mean to me? It's really a philosophy. It's a philosophy of making sure we are doing the best we can for our patients, no matter what stage of the cataract journey, whether pre-op, intra-op, or now the post-op here with the YAG Cap. And it's also then utilizing technology. Of course, we'll talk about some of the Lumibird technology as well, but taking the technology and then really utilizing a technique. And the technique we'll talk about too is using this, what we call a posterior offset. That's a little bit more than you are used to create and to utilize and to harness the power of cavitation. We'll talk about as well. So taking the philosophy, the technology, and then the technique, using that technology to create more efficient, as Gabe mentioned, more efficient, reproducible, safer, in my opinion, YAG capsulotomies that really in some patients may make a difference in their outcomes, which is really the most important thing. Because at the end of the day, I don't care what we do. All we care about our patients happy? Are our patients going out in the rest of the world saying, I love this doctor, I'm going to go back to him, and I want all my friends to go to him or her, right? How do we make sure that happens? It's create that happy patient. And it really is the entire journey. And that's something I've learned in my career so far has been, it's not just about the final outcome, it's the journey they got there, right? How happy were they at the pre-op? How happy were they at their scheduling? How happy were they getting into surgery? How well was the surgery, right? How did it go? How was their experience? And then the post-op period. And then the PCO part of it, whether it happens at a month out or happens at 3 years out, is the final stage, in my opinion, in terms of the journey of that cataract patient. Of course, with ocular surface disease and everything else we talk about, of course, we're managing that the entire process. But that PCO formation and that how we address it and the outcomes of that PCO formation is important. And that's why the YAG capsulotomy is a big part of that journey. And as the end, it's your staple. This is your sign. Like we always talk about incisions, how when someone goes to the doctor, your incision and your capsulotomy, your anterior capsulotomy, is your signature of that surgery, right? Well, the YAG cap is kind of your signature also. And if they go to someone else and they see a YAG cap that doesn't look so happy, what does it look like, and how does that reflect on you and in your surgical skills? And so that's why for me, the PCO and the YAG cap is such a big part of it. And I like to show this video because I found this video and it made me realize how far we've really come in cataract surgery. And watch this, guys. This is a video I found from one of the archives. And it just to kind of put us all in perspective, when we talk about micron differences and 1 millimeter, one degree difference in our toric alignment, and how we're all worried about 2 or 3 degrees, this is what we were doing like in 1920s, but also 1950s, 1960s. Pretty much half of the eye with a von Graefe knife, opening it up, and then taking basically, filling up the eye with some BSS and just really trying to get this cataract out. And it's scary when if you look at this video here, this is the video, I'm gonna fast forward here. They did a PI, right? They go ahead and they take this lens out, right? You see they take the lens out. Now, the favorite part, how are they gonna close this eye, everybody? What do you guys think out there? How are they gonna close it? Steel sutures, some glue, what are they gonna do? All right, guess what they do? So they fill up the eye with some BSS. Not bad. Okay, fine. I'm waiting, and I'm waiting, and I'm waiting, and I'm waiting. Okay, how are they going to close this? Let's not close it. Forget about it. We're done. Leave it open. See what happens. Scary, but that's how far we've come, everybody. So I just thought it's kind of fun to share. We have come a long way, and we should be proud of our kind of profession, part of the industry, a part of us as providers for providing such great care to our patients. So that's why I think the YAG capsulotomy is such an important kind of end result as well. So what are the challenges of a YAG cap? I think we don't have uniform training. I remember, when I was a resident or fellow, it was really kind of like just sit down and aim at the capsule and open it up. I mean, no offense to all my trainers, but that's kind of what it was like, and yeah, we kind of played with power settings. Is it 1.2, 2 millijoules, 2.5, depending on your laser, etc. But there wasn't a lot of uniform training. That was just kind of sit down and just hopefully make an big enough capsule. Don't hit the lens and try to make it big enough so they don't have dysphotopsias. But the inconsistency of the approach and the lack of, I think, education around the world on YAG technology. What's the physics behind a YAG laser? What is happening when you fire a laser and you create that kind of plasma and you create that what we call cavitation? What's really happening? And that's something we don't really get a chance to learn a lot about in residency and fellowship. And that's why I think it is important to talk about tonight, especially in the context we talk about a technique like PROcap as well. And just to kind of reiterate this inconsistency that we see around the world in terms of YAG capsulotomy, this was actually a survey that was done again about a year plus ago. This is looking at about 200 consultants, kind of mostly in Europe and Southeast Asia as well as Australia, just kind of asking doctors kind of how do you do your capsulotomies? What's your technique to use the lens, etc. And it's pretty interesting. About 200 random surgeons were selected as well. And on the left, you see here a question was, which YAG capsulotomy technique do you prefer to use? Whether it's a cruciate or a circular technique or other, meaning we just wing it, which can happen sometimes too. You hit the capsule like, oh, okay, well, I guess I'm gonna do a circular on this one just because how it's breaking up. Right? There's no consistency depending on the surgeon, how you were trained, maybe even the laser you use, or even kind of the patient type. And then the question is, do you use a contact lens? Do you actually put a lens on the surface, or you just go ahead and freestyle it without a contact lens? And again, it's split too. About 50% or so, 50% or so do it, and about more 30-40% don't use it, or some people just kind of depending on the patient. So again, that's the inconsistency of the training, but also with the approach now out there in the community as well. And if we ask the size, there's a number of doctors who do about a 4 millimeter or less capsulotomy, sometimes 2 or 3 millimeters. Now, why that's important is because that can lead to dysphotopsias. If you look at the data sets out there, it can lead to dysphotopsias, sometimes some dimming of vision, whether it's positive or negative dysphotopsias as well. If that, again, especially depending on the type of IOL we use now with our kind of diffractive optics, some of our aberration type of lenses, some of our pinhole type of lenses. There's certain type of lenses now that are different in terms of their quality of vision from the center to the edge of the lens. And if you're making capsulotomy that's, let's say, small, let's say 3 or 4 millimeters or less even, you may not be harnessing the benefits of the entire lens as well. So that's why it's really important to not make those small capsulotomies. And here's actually a picture from a referral I got from a patient who had a dysphotopsia. It said she was having some kind of blurriness in the periphery. And if you look at this capsulotomy that was made, you can see here, this capsulotomy is not really in the center. It was kind of off-centered a little bit there as well. So it's a large enough size for the most part, but there's an area right here where it wasn't actually opened up. So the size, the shape can make a difference. And this is a patient we did the YAG Cap on. I don't have the post-op, sorry, my bad. But we did a YAG Cap on just to clear this area up here and resolve her symptomology. So I think that's important to recognize. Again, this is not every single patient that it happens to, but there are those one-off patients that come in, and that can be a significant impact. Listen, this is a monofocal IOL, not even a multifocal or other premium IOL. And so that's the question, right? How big do we make it? But number two, the other question is, do we use a posterior offset? Now, why do we use a posterior offset? Because we don't want to have pitting, right? One of the things we worry about is pitting a lens, especially in the center of the lens. If it's a multifocal or a specialty lens, you don't want to do that. Or especially now with the Aphthera, the new lens that came out with the pinhole, you don't want to pinhole, you don't want to destroy that. So obviously we go around that pinhole. But the bottom line is, why do we use a posterior offset? Because we're fearful of that plasma causing a pitting. And so if you look here, about 80% of our doctors out there do use a posterior offset, about 20% don't. Question is, how much of an offset do you use? And there was no significant standard, whether it's 100 microns, 200 microns, 300 microns, or it's just you're freehanding it, just kind of just defocusing those two beaming beams and going in the posterior behind the lens. There's a lot of variability to that as well. And this is what can happen. This is another patient too that came to me and had some issues with the quality of vision. And again, I'm not saying it's because of this, but there are data sets out there, depending on the location and the size and the density of the pitting that can happen, it can induce some obscurations to the patient's quality of vision as well. So again, even regardless of the quality of vision, it's your signature. If they go anywhere else and they see that, it's like, hey, what happened there? Now, I'm not saying I've never pitted a lens. Don't get me wrong. We've all have done that. But again, we try to mitigate that as much as possible. And that's kind of where PROcap comes in as well. So let's talk a little bit about PROcap and kind of what it's doing and as well. And can we talk about pitting, which is something that I just showed you as well. And so what do we do and how does PROcap really help us as well? Well, we're going to talk about a couple of things. Number one is the technology, right? We're going to talk about a laser. I use the Lumibird or the LX lasers, the ones, the new here, the Neo. And really the idea behind that is it really gives us the ability to visualize everything we do in ophthalmology. Everything we do in terms of surgically stems and it really is based upon how well we can see. Whether it's cataract, whether it's glaucoma surgery, MIGS, you name it. With a capsulotomy, it's the same thing. Can I see what I need to see? And having the illumination, first of all, the optics and the illumination tower, being able to do what we call coaxial illumination, meaning I can see the red reflex and see some small pieces that I may have missed, hypothetically, or going oblique and be able to see that capsule with a black background, gives us, I think, a lot of, flexibility to really visualize and see what we're actually doing, depending on the patient. Also, the energy delivery. A lot of lasers may have different settings and different energy kind of quality and energy parameters and characteristics. So that's why it's important to have a laser that you use every day, or a similar type of laser, because you can know what to expect, how much power you have to use. What's nice about the lasers that I use with the Lumibird lasers is it has a sharper rise and fall of the Gaussian curve. So in other words, less shock wave in terms of scatter energy, it's more focused, but we'll talk about the harnessing of the cavitation in a second as well. So it's a very efficient, so meaning it needs very low amount of energy to create a plasma in air. It's called the optical breakdown, one of the lowest optical breakdowns of any laser we have. And it also has stability. As you fire, we don't see variations. We did a data set that we presented a few years back showing that more consistency, no matter how many shots you fire, even 100, 200, 300 shots, hypothetically, the laser delivery is stable because of the cooling cavity that it has as well. But let's talk about PROcap and what's the basis behind this. So we're going to talk about the technique in a second, but I want you guys to understand this concept of cavitation. Now, we talk about cavitation a lot and the cavitation creation in phaco. So part of phacoemulsification is the ultrasound energy, right? The oscillation, right? Of back and forth, depending on your phaco machine, 28 kilohertz, 48 kilohertz, whatever it might be. But that oscillation is creating mechanical breakdown of the lens, right? But then it also creates cavitation. Cavitation are air bubbles or gas bubbles that form, right, from the motion, the movements, right? And or in this case of the YAG laser, when you have plasma formation, you have a plasma cone that forms, and then gas bubbles form, which is basically these gas vapor bubbles. The vapor bubbles have a life cycle to them. So the vapor bubbles grow in size, they get big enough, and then they implode. And as they implode, that power of the implosion is that microjet of that implosion is what we can harness to create the larger capsulotomy, the opening, without having to worry about the plasma itself causing destruction. Because again, what happens that the vapor bubble comes towards a source. So you fire the laser performs a plasma spark, right? But then that vapor bubble will come back towards a source. So we can offset 2 millimeters even, offset posterior to the capsule, fire the laser with that plasma, right? So we're far enough away from the plasma, only like 100 microns, 200 microns in terms of its size. So the plasma is far enough away to cause pitting, but then we can allow for the creation. We need enough distance from the capsule to the plasma creation for that for the vapor bubble to form, for this life cycle of the cavitation to form. So if we're not far enough back behind the capsule, we don't allow enough time, enough distance for that cavitation bubble to form. But once it forms and it kind of implodes on us, we can use that to break the capsule. What does it do? Minimizes pitting, and for each shot gives us a larger surface area that we can break up with each shot, so therefore we're more efficient as well. And a lot of this, as Gabe mentioned, a lot of this, Carl and I have gone way back many years with laser vitreolysis and other things we've done in the past. And so we've been kind of both of us learning so much about YAG capsulotomies and YAG lasers and the kind of how they work and what the mechanism of action is. And so he and I, and give a lot of credit to Carl, decided let's get a larger posterior offset, again, to allow us to harness the benefits of that cavitation. So this is a schematic here showing you on the top there a capsulotomy, or a capsule that's kind of opacified. And what people would do historically is offset the aiming beam. So you have an aiming beam at the capsule here. But if you wanted to go posteriorly, you'd offset it. You defocus your aiming beam so you're posterior to the capsule, and that will give you about a 2 millimeter posterior offset manually, is what we would do before the new laser came out. We would manually defocus about 2 millimeters back to create a nice larger size. Because again, if you're 2 millimeters behind the capsule, you're going to create the cavitation and then harness that power. So each shot gives you a larger surface area that you're breaking up, like on the bottom left here. And then if you look here, you can go ahead and you can break it up 1, 2, 3, 4 to get a larger size. So then you can end up having a nice, large, even distributed capsulotomy that's near the edge of the optic. So you can you can harness the benefits of the entire optic. And because these shots are getting a larger surface area, you're not getting smaller creation that can cause more iatrogenic floaters. Because what happens if you're doing shots here, small shot, small shot, small shot, and there's only a small amount of capsule breaking up, you create those small pieces that can cause more likelihood of floaters. Now, I'm not saying I don't create floaters. I have done that too, of course, even with this technique. But we can mitigate some of those creation of floaters by creating larger flaps, we call them, versus smaller little pieces that break up and cause those patients who complain of floaters. So let's go back to this video here. Sorry about that. Let me go back one more slide here. This is just a video that's showing you what we're talking about. So again, we're doing a 2 millimeter posterior offset. So on the YAG laser that I use, the Neo, we have a 2 millimeter, 2000 micron posterior offset that's already preset. So I can turn it to that. So that way I can aim at the capsule with my aiming beams, but it's giving me a 2 millimeter posterior offset. Now, when we fire a laser, what's happening? That 2 millimeter offset is firing a laser behind the capsule, right? So right now we're firing a laser, and there's a plasma cone firing 2 minutes behind the laser. But by doing that, it's far enough away where we're not going to break up with the plasma, the capsule. We're using the cavitation to break up. So you go one click, you're firing one click there, and then we can do another click to the left, to the right here in each quadrant, and that creates a larger and larger and larger spot. So we can aim at the capsule, but with a 2 millimeter offset, we can aim at these edges. See there? We create at these different edges here. And because we're creating a larger shot, this is called Ross's video. See how he's aiming at the edge there? He's aiming here one more time at the edge. He has beautiful videos, by the way. Got to give him credit for that. And so you can see he's aiming at the edge and see how much more, and he's creating these flaps he's not creating small pieces. And the only way to get that larger amount of surface area is by creating that distance for that cavitation bubble to form to create that larger area as well. And that's how you minimize pitting and minimize creation of those iatrogenic floaters as well. So this is me in our laser room as well, going to that 2 millimeter offset. So you can see here, I'm just turning it here, just to 100, 200, 300, 400, 500, 600, 1,000, and there's 2,000. So 2 millimeter posterior offset is what we're using. Now you can do about 1,000 or so. If you look at the data out there, you need about a millimeter and a half to create enough distance for that full cavitation. So some people could go to 1,500, some people go to 1,000, but I go about 2,000 microns, 2 millimeters back, and I'm using higher energy levels. We'll talk about that in a second as well. I'm using about 5 millijoules. This is one of my videos I'll share with you, and I'll explain the power in a second as well. So I'm going to go ahead and I'm firing, and I'm aiming at the posterior capsule. So my aiming beam is not offset or defocused. It's at the posterior capsule. But because I have a 2 millimeter posterior offset, it's automatically going to give me that cavitation creation. So I'm just going to fire, and look at the distance here. There we go. See there? So see, I'm creating these larger spots here. And there's some gas bubbles forming as well. But you see, I'm creating nice openings. I'm not actually creating smaller pieces there. There we go. Kind of like Carl did. Now, this is not a retro or a coaxial illumination view, but you can see here the caps are breaking up, and I'm going to those edges. So I'm creating those flaps like Carl did. And what that does is, again, minimizes the iatrogenic floaters, and I'm getting far enough away, so I'm getting as much of the capsule to the edge of the optic. So that way I can, again, utilize the entire properties of the optic as well. And so you can go ahead and do more if you need to here. You can see I'm just going to edges, and I'm going to go in, and I can create nice clear edges. And if I see any small pieces, I can go ahead after those pieces if I need to as well. So that's the benefit of that cavitation creation. And I'm going to show you in a couple seconds why the illumination tower is so unique with this technology, with the Neo. I love it because it's something called coaxial illumination. So it has a flipping mirror system. So when you fire, the mirror goes out of the way. And you can do, by the way, SLT. There's something called the Tango Neo, where you can do SLT, or you can do YAG capsulotomies, and you can use this coaxial illumination or oblique with either one of them. But the bottom line is it allows you to fire not just in the oblique position like our standard YAG lasers do. We can fire with the coaxial illumination. And why that's important is because when we fire with the illumination, we can see a good red reflex. And that red reflex allows us, and this is showing you when you fire, that mirror goes out of the way. So I have good visualization, and my illumination tower and my visualization, my oculars are all on the same optical pathway, as well as the laser. So we're all on the same pathway. That gives us true coaxial illumination. And what does that mean? I'm just going to show you something here. When you fire this laser and you're coaxial like this versus off axis or oblique, when you're oblique, you get that black background I showed you earlier. But when you're coaxial, you see that red reflex there. That's important because when we want to look for things like iatrogenic floaters, we want to go for those. If there is a small piece you created, how do you prevent that patient from having floaters afterwards? So here's an example. This is one of my patients here, and I'm going to show you the benefits of coaxial illumination. So I'm just going to fast forward here. So I'm done with my YAG cap, and you see here, I have some of the small pieces hanging out. I couldn't see them when I was here. This is where it's oblique. Now I go coaxial, and look at those small pieces I couldn't see. So by going coaxial, you can kind of double check to make sure there's no small pieces that you may have created by mistake, and you can go for those pieces. When you're oblique and you do not have the coaxial illumination, it's hard to see those small pieces, and that's when patients go home and say, they come back a week or two later and say, hey doc, I have all these new floaters, what'd you do to me? And so that's a nice benefit of using the coaxial illumination as well. And we presented a paper at ASCRS a few years back here, a very small paper that was prospective, actually looking at the risk of formation of floaters, iatrogenic floaters, after YAG capsulotomy. We found with the Tango, which is basically the non-coaxial group, we had about, at 2 to 4 weeks, about 37% of patients who still had floaters. And with the reflex technology, this is the previous version of the Neo, showing us 0 patients had complaints at 2 to 4 weeks. About 25% of patients at about 1 or 2 weeks did complain of a floater here and there. So significantly less amount of patients were complaining of floaters because we had that coaxial illumination to double check as well. And so that's a nice benefit. I mentioned also too this whole idea of energy delivery, and we can see here that we have stability of energy delivery even after we fire. This is a study we did also presenting at ASCRS. Even at 200 or 300 shots, the stability of the energy delivery is the same versus a laser that does not have a cooling cavity like this. You see variability as you fire more than 20, 30 shots as well. So the delivery is not the same as well. What's nice too about this laser and kind of talking about the technology as well, I think is kind of neat, is the fact that we also have this kind of display that tells us the power, right? So we can look in our oculars, we don't have to look away at the screen to see kind of what the power settings are. So we can change our power settings and have a heads-up display, so to speak, in our oculars as well, which I think is kind of a nice feature as well. And this joystick kind of allows us to kind of change the functionality as well between YAG and between SLT as well. And there's a touch screen too that allows you to kind of help knowing what you're doing. Very intuitive, very easy to utilize as well. And I think something that could be a nice advancement as well. It also gives you a nice list of your patients that can also directly connect to the EMR as well, which is kind of give you like an op report as well, which is also, I think, a nice benefit as well. So another example of this PROcap here. So again, bringing it all together, again, this is not the best view, I apologize, but the bottom line is we're using posterior offset of 2 millimeters, 2000 microns. We're using the power of cavitation creation. So we're actually not using the plasma itself to create the breaking of the capsule, the cavitation. So that's where we do less pitting. We're also going to use, again, the illumination tower as well. So here you go, just kind of showing you, this is the non-coaxial view so you can see it. I'm going to fire right at the capsule there. You see, boom, there we go. See how big that surface area is? With every shot, I'm seeing a larger amount of the capsule being broken up versus trying to go for each small shot. So you can go in the center, you can go in the periphery, however you like to do it, but you can create these nice large areas. And I'm not worried about pitting. And these are all gas bubbles that form. Now, the couple of questions that a lot of times people ask me is, well, doc, what about the power settings? I'm using about 4 to 5 millijoules. Now, that sounds scary to a lot of patients, a lot of doctors who are using 1 or 2 millijoules, right? But to me, to create that cavitation, we need to have that enough energy. But what's good thing about the energy, if you look at the data, it's a non-linear relationship with the size of the plasma creation with the amount of energy in the laser. So for example, I'm just going to go ahead and, by the way, this is my email. If you need me at all, anytime, please feel free to reach out. But if, for instance, if you have, and I'll stop sharing for a second here, if you have, here we go, 1 millijoule, you look at in vitro, looking at the size of the shock wave of the plasma, it's about 110 microns. If you go to 5 millijoules on the laser, the amount of dispersion of that shockwave, that plasma cone, is about 220 microns. So less than 50% increase in size of the plasma cone, despite going to, or even at 10 millijoules rather, it goes to 220 microns. So even despite 10-fold increase in energy in the laser setting, you're only minimally increasing the size of the plasma spark. So that's why we feel very comfortable going to 4 to 5 millijoules and not causing collateral damage. What we're doing is using and harnessing the benefits of that cavitation. So that's why I go to 4 to 5 millijoules, 2 millimeter posterior offset, to allow ourselves the best ability to create that larger opening of the capsule, minimize the actinic floaters, and again, create large enough capsulotomies where it goes all the way to the optical edge of the lens. Because again, we don't want to minimize the benefits of some of those special lenses as well. So that's the idea of PROcap. It's not revolutionary, but I do think it's important as a natural progression when we talk about getting better as surgeons in terms of YAG capsulotomies and the whole cataract journey, minimizing pitting, minimizing actinic floaters, and creating those consistent large openings that we need as well. But with that said, thank you guys for showing up tonight and sharing a night with me. Hopefully it wasn't too long, but I'm going to stick around here. If there's any comments or questions, Gabe, from the audience, feel free, and I'll be here to answer those questions.
Perfect. Thank you, Dr. Singh. Yes, we do have a few questions here. One of them is, can I do PROcap with my current laser if it is not a Lumibird laser?
Absolutely, you can. You can. To be fair and balanced, you can do this with any laser. This is a technique. Now, I do, as I mentioned, I like the Lumibird laser because the energy delivery, the illumination tower, the settings, the 2 millimeter offset, all that stuff we talked about, right? But yes, you can. You can manually defocus. And this is what me and Carl were doing before we had the 2 millimeter offset. You're manually defocusing, and then you're firing. So yes, you can do that as well. Now you may have to kind of manually adjust how far back you are and kind of just troubleshoot, kind of visually look and see, okay, did it fire? Was it too far back? Move it anteriorly. Oops, I'm too far anterior. So that's the only negative of not having that 2 millimeter offset on your setting on your laser. But yes, you could use any laser. Again, every laser is going to have a different profile and a different characteristic of the energy delivery. So that's why my 4 or 5 millimeter or millijoules in the Lumibird laser may be different than whatever laser you're using. But yes, you can use any laser. Absolutely.
Okay. The next question is, what lens do you typically use for YAG PROcap, or do you not use a lens?
Great question. I love using lenses, and I'm a big fan of the lenses because I do think it gives us, so it enhances the power, by the way, it enhances the power of your energy delivery. It's more consistent, as well as you take away some of the corneal abnormalities too that can limit the energy delivery as well. And I think I have a better view. So I do use a Abraham lens is what I use for most. I know Carl Braza has a new lens that he's come out with. Is a beautiful lens as well that I'm going to start using. But I think most of the typical YAG capsulotomy lenses like the Abraham and other lenses are absolutely fine. And I think that helps me provide more consistency, as well as I think the energy delivery is more consistent when firing.
Okay. And the next question is, are you aiming for the corners after the first shot? Are those also at 4 millijoules?
Everything, I keep it at 4 to 5 millijoules. And so I make one. So my technique was one in the center, as you saw in that schematic that Carl did, which gives you about 2 or 3 millimeter, maybe more, depending, 3 millimeter opening usually, right? Because again, that cavitation. And then if I have this kind of trapezoidal kind of thing right then, I'll go for a corner here, go for a corner here, go for a corner here, go for a corner here to create it bigger. And then go for each corner again to make it bigger. So you're going from inside out, and you're creating these kind of flaps, right? And so that you don't have these small little pieces. Now, as you saw, that other video I showed you with the laser for floaters when I was kind of like the isogenic floaters that was created with that study we did, that was with the previous PROcap laser when I wasn't doing the 2 millimeter offset. But the coaxial illumination allows you to see those small pieces. I don't see as many of those small pieces anymore by doing PROcap, meaning by going 2 millimeters behind and utilizing this energy of 4 or 5 millijoules, because again, those larger flaps are being created. So that's kind of my technique, center to out versus going in the starting the corners. But when I do that, when I create that center kind of hexagon or whatever you want to call it, I'll go for those corners of those flaps and then create them larger flaps, larger flaps, larger flaps. I'll keep going to the corners until it gets larger and larger and larger. And you can customize it. You can be very precise and create beautiful circular capsulotomies. Did I lose you?
Sorry, I was on mute. What lasers?
Sorry.
Sorry,
I was like, oh, I'm frozen. I'm frozen. Like
no,
sorry.
It's what lasers have reflex technology for coaxial illumination?
So from my knowledge, and I may be wrong, Gabe, you maybe want to correct me if I'm wrong. I think Lumibird is the only one that has that flipping mirror coaxial illumination tower. Is that correct?
Correct.
Okay.
Yes.
So from my knowledge, now there are other lasers that have something called a dual mirror system, which is kind of like, basically imagine you have two mirrors like this, and the light source kind of converges to create a pseudo coaxial illumination, which does work pretty well, to be fair. It does work well. Not the same, you can't kind of titrate the tower quite as well as this flipping mirror system, but there are other technologies that do use a dual mirror type of system. From my knowledge, the only one that has that flipping mirror type of technology gives you true coaxial illumination, the entire field of the illumination going into the back is this flipping mirror. And that's the Tango Neo, the older Ultra Q reflex. So anything that has reflex on it has that flipping mirror system. And the new Tango reflex, for those of you who have Lumibird lasers, remember the Tango reflex before the Neo came out, you had to fire the SLT in a non-coaxial kind of slit lamp position, which for me was okay, but it took a while to get used to that. Just kind of, you get used to coaxial SLT, and then you have to go oblique. Well, with the Tango Reflex Neo, what's nice is that you can actually use now the Tango Reflex. You can use the SLT in the coaxial position, and you can do YAG capsulotomies in the coaxial position as well, which I think was something that was a nice change that they kind of brought back again.
All right. And then the next question is, do you use goniosol as a coupling agent? And if so, what do you use when there is a national shortage?
I love viscoelastic. First of all, Gentile gel works great. So I don't really use goniosol anymore. I used to get some cornea issues, a little bit of some toxicity in some patients, even some edema I've had in the past with goniosol in personal opinion. So I don't use goniosol anymore, but I love Gentile gel. I think Gentile gel is great. It's easy to get and it works well, keeps the surface nice and coated. If not, you could use viscoelastic. Worst case scenario, you could use a viscoelastic of any sort if you need to. You can kind of buy any kind of cohesive viscoelastic, and that usually works. But for the most part, Gentile gel is really what I use for most of my cases.
All right. That's all the questions that I have.
Awesome. Well, I try to keep it about a half an hour, so we did it, because I don't think we could talk for an hour and a half on the YAG capsulotomies. But guys, everybody out there, thank you for spending time with me. Look, again, my goal is just to kind of share with you my thoughts on this. I think the YAG capsulotomy is such a ubiquitous procedure. That's the first thing we learn in residency, but I think we can do better. I think we can do better, like in everything we do. We change our techniques. I think we kind of help be more precise with our techniques intraoperatively in surgery, right? Whether we do chopping and how much energy we use, and post-op corneal edema, we try to get better and better at as well. It's the same thing with YAG capsulotomies. I think we can all do better, and this is another natural evolution, in my opinion. Please keep in touch. I sent you my email. I put that up on the screen earlier. Anytime you have any comments or questions, want more videos, want to share some thoughts, please feel free to email me anytime. And thank you again to LumiBird and to Gabe for letting me share my thoughts with you guys.